Hello, my name is Mazen Zaher. I'm a fourth-year neurosurgery resident at Philadelphia College of Osteopathic Medicine. The title of our study is Seizure Prophylaxis in Mild Traumatic Brain Injuries with Intracranial Hemorrhage. This is a prospective cohort study that involves the Department of Neurosurgery, Neurocritical Care, and Trauma Surgery at Cooper University Hospital. So the story starts with the Brain Trauma Foundation guidelines. In their last edition, the fourth edition, they gave recommendations about seizure prophylaxis for the management of severe TBI patients. They gave a level 2A recommendation that phenytoin was recommended to decrease the incidence of early post-traumatic seizures, which was defined as seizures within the first 7 days after TBI. And then they mentioned afterwards that there was no sufficient evidence to recommend Keppra over phenytoin in regards to efficacy in preventing early post-traumatic seizures and toxicity. They kept a lot of questions unanswered because of that. They also added that there were risk factors for early post-traumatic seizures, and some of these risk factors were a GCS less than 10, having immediate seizures in the post-TBI setting, having amnesia lasting for more than 30 minutes, if a patient has a linear or depressed skull fracture, if there was a penetrating head injury. And the next thing which I highlighted, and it's very important because it determines a lot of times whether patients get treatment with anti-epileptics or not, is whether they have a positive head CT, which is having a subdural, epidural, or an ICH or cortical contusion. Notice that traumatic subarachnoid hemorrhages were not mentioned here. And having a patient younger than 65 years old with chronic alcoholism increases your risk for an early post-traumatic seizure. So then what should we do with patients with mild and moderate TBI? Should we treat them with seizure prophylaxis, or should we not treat them with seizure prophylaxis? Because of that question, we started our study. And the objective of our study was to compare the incidence of mainly post-traumatic seizures in patients who received seizure prophylaxis versus patients who did not receive seizure prophylaxis in the group that would be classically classified as mild based on their GCF, except that these patients would have a positive head CT defined by having a non-surgical intracranial hemorrhage on a CAT scan. So we collected data on patients who suffered a traumatic injury and had a positive head CT from January 1st, 2020 to July 15th of 2020. We also collected information on their alcohol history, if they were on any anticoagulation, if we gave them or did not give them anti-epileptics, and what kind of CT findings they had, what kind of bleeds they have. And if EEG was collected, the results of the EEG. The primary outcome that was studied was the incidence of early seizures. If you look on my right, just on the patients that we had 208 patients, 78.4% of these patients were in the mild TBI group. That's why it's important to know whether we should treat these patients or not, because they consist the majority of patients who are admitted with a positive head CT. About 10.6% were in the moderate group, and 11% were in the severe TBI group. We were studying the patients that were in the mild TBI group, those 163 patients. Patients were excluded if they were younger than 18 years old, if they had a history of seizures, if they had a history or were operated on, if they specifically had a cranial operation, if they died within the first 7 days, and if they had no follow-up. The total excluded were 67. So how did we place the patients in which group? So because there were no specific guidelines to treat these patients, there were variability in how we treat them. So 3 of our attendings at Cooper do not give seizure prophylaxis to patients with mild TBI and a positive head CT. On the other hand, 2 attendings gave seizure prophylaxis to all the patients for 1 week, excluding traumatic subarachnoid hemorrhage, which is thought to have a lower risk of seizure. So we ended up with 96 patients with a mild TBI and a positive HCT. 35 of these patients were placed in the anti-epileptic prophylactic group and got seizure prophylaxis. Almost all of them got Keppra, a loading dose of Keppra 1,000 and admission, and then 500 twice a day afterwards for 7 days. On the other hand, 61 patients received no seizure prophylaxis. So we also tried to standardize our way we diagnose seizures. A lot of these mild TBI patients were discharged home before the 7 days. So we called them after 7 days using this screening form, which is a modified form from Autumn and Al, to screen for seizures. And we asked them the following questions. And if they answered yes, we would flag them as having a seizure in the outpatient setting. For patients who were still inpatient for the first 7 days, we used the chart and we worked with the neurocritical care team to diagnose them. If they fit a specific seizure semiology, they were diagnosed by the neurocritical care team, and it was documented clearly in the chart that they had a seizure. If things were vague and there was some kind of motor activity that looked like seizure, but we were not sure, an EEG was employed, and the final result on whether the patient had a seizure or not was documented by the neurocritical care team based on all the information that they had, including the EEG. So our results show that for the patients that received seizure prophylaxis, we had no seizures in that group. For the patients that basically did not receive seizure prophylaxis, there was one patient that had a seizure out of the 61 patients, which was 1.64%. But there was no significant difference in seizure incidence between both groups. So in conclusion, there's no significant difference in early post-traumatic seizures with patients that receive seizure prophylaxis versus no seizure prophylaxis in patients with mild TBI and a positive HCT. Now, our study had some limitations because of the smaller study groups and population. It was only powered to detect a 17% difference in seizure rate, but we are overcoming that by continuing to enroll and add more patients to improve the power of our study. If there's any questions, I'm happy to answer.